Good morning, everyone. If we are ready to get started, we can start. My name is Sue Ann Bell. I'm an assistant professor in the School of Nursing, and I'm a member of IHPI's Early Career Faculty Council, Advisory Council. And one of the things we sponsor is an Emerging Scholars Lecture Series exchange. So I'm really excited to get to host and introduce our first emerging scholar of this season, Dr. Lily Brown. Dr. Lily Brown is an assistant professor at the University of Pennsylvania and the director of the Center for Treatment and Study of Anxiety. She's a licensed clinical psychologist and an assistant professor in the Department of Psychiatry at the University of Pennsylvania. She completed her pre-doctoral internship at Brown University and her graduate training at the University of California, Los Angeles. Her research expertise is in the intersection of anxiety-related disorders and suicide risk. She has grant funding from the Department of Defense and the National Institute of Mental Health to support her research in this area. So please join me in welcoming Dr. Brown. Thank you for coming.
Thank you so much for having me. I've been advised to stay here so that the video can see me, so my apologies for the folks behind the podium. If you're having a hard time, I think there are some empty seats over here if you prefer to move, but it is really my complete honor to be here with you today. Over the holidays this winter, I was sharing with my in-laws who live on Torch Lake most of the year that I was coming to do this, and my mother-in-law gasped and said, "You know they're really famous, right?" And I said, "I know, they are. I'm so excited." So my whole family is so proud of me because of this moment, so I can't thank you enough. So today, just to present an agenda for what I'll be talking about, I'll begin with a brief background about the intersection of trauma-related distress and suicide risk. And then I'll jump into some of my research on mechanisms of the change in suicidal ideation in the context of trauma-focused treatment. After that, I'll describe a bit of my research about digital phenotyping, which for those of you who are unfamiliar with that term, this is essentially strategies for picking up the digital fingerprint of an individual to predict some outcome of interest using active and passive assessments. And then I'll summarize and describe some future directions for this research. And I plan to leave about 15 minutes at the end for questions and discussion as well. So for those of you who are unfamiliar with post-traumatic stress disorder, in order to meet criteria for PTSD, an individual first has to be exposed to a criterion A trauma. So this can include actual or threatened death, or serious injury, or sexual violation. But trauma exposure alone does not necessarily lead to the development of PTSD. An individual meets criteria for PTSD if they also experience a variety of symptoms, including symptoms of hyperarousal. So here think problems with sleep, as well as problems with hypervigilance, that sense of being unable to relax, as well as negative alterations in mood and cognition. So here think about problems with connecting with other people, feeling isolated, as well as loss of interest in things that you might usually enjoy. Intrusion symptoms, so unwanted memories about the trauma or nightmares about the trauma, and of course avoidance. And avoidance can manifest both in terms of internal thoughts and feelings that are intended to be avoided, as well as external reminders of the trauma itself. We know that the vast majority of people in the United States will be exposed to a trauma at some point in their life. The most common types of traumas in the US include unexpected death or injury of a loved one, as well as physical or sexual violations. Fortunately, the vast majority of people who are exposed to a trauma do not go on to develop PTSD. About 8% of the population in terms of lifetime risk will at some point meet criteria for PTSD. But for those who do, the disorder is extremely chronic. There are studies tracking, for instance, Vietnam veterans showing that they will continue to suffer with symptoms of this disorder if it's untreated for their lifetime. It's also extremely impairing. So PTSD leads to problems with employment outcomes, relationship outcomes, educational attainment. The disorder is extremely costly. Some estimates suggest that almost $70 billion annually in the United States are attributable to PTSD or its consequences, and it's highly comorbid. The comorbidity that I'm particularly interested in, as you have gathered from the topic of this talk, is suicide. And one of the reasons why I'm really interested in the intersection of trauma and suicide is in part because of the rising rates of suicide in the country in the past 2 decades. So here I've presented some data that comes from the Centers for Disease Control and Prevention. We know that in the past 2 decades, there has been a slow and steady increase in suicide rates in the United States. And that's interesting because that's not the case in every Western country throughout the world. About 25% of countries in the world have seen rates increasing similarly to ours, which means about 75% of countries have not. So there's something going on in the United States and in some other countries that are particularly concerning in terms of suicide risk. This is also interesting because there have been billions of dollars pumped into trying to reduce suicide risk in this country, and yet we continue to see these steadily rising rates over time. We're at a point now where suicide is the 10th leading cause of death in the United States, such that there is 1 death by suicide, 123 deaths by suicide each day. And for every suicide death, there are 25 additional suicide attempts. So to me, this really speaks to the enormity of the challenge that we're up against in terms of trying to reduce suicide risk. I've published a number of papers, as have my colleagues, to indicate that post-traumatic stress disorder is an important predictor of suicide risk. This is now a pretty well-established finding in the literature, but I'll present to you just one study that highlights this. So when I was on my internship at Brown, I was interested in trying to understand how PTSD might alter suicide risk among very high-risk patients. And so for this, I used patients who were on a psychiatric inpatient unit, with the idea being these are some of the most high-risk patients that we could possibly find in terms of suicide risk. So what happens for them if they have a diagnosis of PTSD in terms of their suicide risk? And what I found was that individuals who had a diagnosis of PTSD, represented in the 2 bars on the left, were much more likely to have some history of a suicide attempt compared to individuals without a diagnosed history of PTSD. And furthermore, individuals with a history of abuse, regardless of whether they had a documented history of PTSD, were much more likely to not have just 1 but multiple suicide attempts. And this is just one of many, many studies at this point that have suggested that PTSD is an important predictor of suicide. Now, there are a number of theories that I use for guiding my research and trying to understand why PTSD might be an important risk factor for suicide. And these theories draw from the anxiety disorder literature and, of course, the suicide prevention literature. So first, I'll present to you a theory from the anxiety disorder literature to help understand why this is an important trajectory. So there's a theory in the anxiety literature called inhibitory learning, which was a theory that I was working on heavily in my graduate training. The idea here is basically that trauma-related stimuli, which can include people, places, sensory details, objects, stimuli that were present at the time of the trauma, come to represent the attribution of danger, such that these stimuli alone elicit perceptions of risk and of threat, even in the absence of actual objective risk or threat. And the goal for trauma-focused treatment is essentially to form a new alternative and inhibitory association. Put very simply, the idea is instead of these stimuli representing danger, we want to train individuals to reconceptualize these stimuli as representative of safety. So this is really the goal of most trauma-focused treatments, is to change the attribution of relative danger to relative safety. Linking this to theories of suicide, there are many theories of suicide that I think we could talk about today that have a lot of merit for understanding the development of suicide risk over time, but I'll just present one to you. So this is the 3-step theory of suicide, which was published by David Klonsky and Alexis May a few years back. This theory essentially suggests that for an individual to start thinking about suicide, there are 2 conditions that must be present. An individual must be experiencing some amount of psychological or physical pain, plus hopelessness about that pain. So it's not just that I'm in pain, it's that I think I'm never going to be able to escape from this pain. I'll never be able to move past this in my life. Some individuals, though, never develop severe suicidal ideation, whereas others do. And the theory goes that individuals that are interpersonally connected to other people are protected against the development of more severe suicidal ideation. And the converse, individuals that are disconnected are more likely to develop more severe suicidal thoughts over time. Fortunately, the vast majority of individuals that are at risk for suicide or that think about suicide never engage in suicidal behaviors. So that's a good thing. But those that do engage in suicidal behaviors are thought to have three kinds of factors. So the first is dispositional factors. So this is genetics, biological sensitivity toward reactivity, or a number of other kind of factors that a person might be born with, as well as acquired factors. So here think environmental exposures or life experiences, and practical factors. Here think access to lethal means. So it's the combination of these factors that are thought to help a person transition from just thinking about it to engaging in suicidal behavior. Linking this to PTSD, an individual with PTSD has a number of examples of psychological and physical pain. One example is heightened startle response. So that perception of never being able to relax, never being able to just turn it off, always feeling a heightened sense of reactivity is extremely uncomfortable for individuals with PTSD. Plus, they tend to report perceptions like, my life's never going to get better. I'm never going to be able to get out of this. It's also common for individuals with PTSD to feel, I just can't relate to other people. This is a core symptom of PTSD. And violence exposure alone, as is often the case with PTSD, might be an important acquired risk factor for suicide. Plus, individuals with PTSD might be more likely to, for instance, own a firearm or some other lethal method to protect themselves because they feel unsafe all the time. And we know that accessing a firearm can put someone at higher risk for suicide. So the goal for the treatment development work that I'm doing is to try and find strategies for, of course, inhibiting startle responses and other sources of psychological and physical pain, for altering cognitions, both about hopelessness and about connecting to other people. And while we can't change exposure to violence or other acquired risk factors, we can alter access to lethal means, which certainly doesn't mean necessarily getting rid of firearms, but it might mean changing the way that firearms are stored or secured in the home to create a barrier between the weapon and the suicidal urges. And so this is really the goal of a lot of the research that I'm interested in these days. So now we'll transition to talking a bit about some of the research that I'm doing on trying to understand mechanisms of treatment response in terms of the change in suicidal ideation in trauma-focused treatment. And so there are two research questions that really guide this area of research. The first is, how does suicidal ideation change, just in general, in the context of trauma-focused treatment? And what really mediates this reduction over time? To begin, I'll present to you some research that I've done to look at how PTSD and depression changes over time, because we know that depression is also an important risk factor for suicide. And the basic idea behind this area of research was to explore, on a particular treatment session, the extent to which PTSD symptoms might drive subsequent symptoms of depression, or the opposite. So do we see evidence for unidirectionality between these relationships, or is there evidence for bidirectionality? So to do this, I collapsed data across 3 different randomized controlled trials using a variety of shared measures of PTSD and depression severity, each of which were administered for 10 sessions, while patients were going through a treatment called prolonged exposure therapy. So for those of you who aren't familiar with prolonged exposure therapy, this is a treatment that's really intended to target avoidance and cognitions about the trauma by helping patients to talk through the trauma-related memory. The idea here is that individuals with PTSD are so averse to thinking about the trauma that they'll do whatever they can to try and suppress the memory of the trauma. And that makes it so that the memory gains more weight over them and invades their consciousness at the most inconvenient times. And so this therapy is essentially premised upon the idea of helping patients to talk through the trauma memory and to approach things that remind them of the trauma to develop these new inhibitory associations. Here are some demographic details just to describe the sample. We won't get into a lot of detail about this, but they're here for people that are interested. So what did we find? So we found that, not surprisingly, if we look at our measure of PTSD severity over time, we see that there's a strong correlation between PTSD severity on a given session and the next session, and also, not surprisingly, between Beck depression severity, so this is a measure of depression severity on a given session and the next session. We found evidence that PTSD on a given session significantly predicted depression the next session. But we also found evidence for the opposite effect. So essentially, through a variety of different combinations using this cross-lag panel analysis, we're able to narrow in on the finding that someone's PTSD symptoms might affect their downstream depression symptoms, but also the opposite. And so this is important for thinking about where do we try to intervene to reduce suicide risk? Is it on the PTSD or on the depression, or maybe both? And so we'll return to that in just a moment. I'm going to present to you some findings from a large study that was conducted in active duty military personnel. And this is one of the largest PTSD trials of its kind that included active duty military who were on return from deployment from Iraq, Afghanistan, or nearby locations, all of whom had a diagnosis of PTSD. And the methods for this study were somewhat complex, but essentially all you need to know is that individuals were randomized to receive either prolonged exposure therapy or a non-trauma focused treatment. So this is sort of a supportive counseling intervention focused on problem solving, not at all focused on processing the trauma or talking through the trauma, or waitlist. And the demographic details for this study are also presented here. So individuals are around 30 years old on average. Because of the sample, these are primarily male, primarily married with some college experience, and also with some racial and ethnic diversity, but primarily white. Measures for this study included a measure of PTSD severity, the PTSD checklist, as well as a measure of suicidal ideation severity, the Beck scale. We also have a measure of depression severity and a measure of social support, in part because of the importance of social connection to the development of suicide risk. And we collected this information at the beginning, middle, and end of treatment, and at a series of follow-up time points as well. So the first project that I conducted with this data was in an effort to understand how PTSD symptoms change over time. The underlying idea here is that we often assume in clinical trial research that we want to compare response to the group mean change for treatment A to the group mean change for treatment B to see whether a given treatment is efficacious. And of course, there's a lot of value in that approach, but we lose a lot of information by collapsing across individuals. So in an effort to understand how PTSD symptoms change over time, I used an approach called latent profile analysis, or sometimes called latent trajectory analysis. The idea here is I wanted to understand how individuals change over time, not just that they do or do not improve. So to do this, what I've mapped out here is change in a measure of PTSD severity over the course of 10 sessions of the psychotherapy. And basically, we want to see that by the end of treatment, individuals are lower than this red line. This represents clinically significant change on this measure. So first, I'll present to you the different profiles that emerged for participants that were in our PE condition, our prolonged exposure therapy group. What we see was that there was a group of what we called rapid responders. These are people who get better really quickly, and they tend to stay better over time. Then there was a group of what we called steep linear responders, people who got also better quite quickly and in a mostly linear fashion. And then a group of what we called gradual responders, so people that took a little bit more time but eventually got there. So this was interesting, but I actually found the last two groups of this profile analysis to be the most interesting. Those included a group of what we called non-responders. So these are people who never reached that benchmark of clinically significant improvement throughout the course of the therapy, and a class of what we call symptom exacerbation. So these are people who actually got worse throughout the treatment and stayed worse throughout the course of by the end of the treatment. So this was really interesting and somewhat concerning as a person who's doing a lot of research in this treatment, that by and large we often see this treatment is helpful for patients with PTSD symptoms, but it's certainly not universally helpful. And this was one of the first attempts to show different directions of change over time. But what was also interesting here is if we map on what happens in our prolonged exposure group here on the left, compared to our supportive counseling group, our non-trauma focused treatment group, what we see is remarkable similarity in classes, in whether the person was in the trauma focused group or the non-trauma focused group. So essentially, there were slightly fewer rapid responders in the supportive counseling intervention, and there were slightly more people that got worse, this symptom exacerbation class, but there remained about 5 classes of symptom change over time. So to me, I think this is really important to suggest that we need to be doing better to understanding how do we target and improve PTSD symptoms among these last 2 classes of people that are currently not responding to our evidence-based practices for PTSD. I followed this with an exploration of what happens in terms of the change in suicide risk in this same sample, again, of active duty military personnel. So my first approach for exploring this was just to look at the overall group change, to see what's happening in terms of change in suicidal ideation. So when we compare our waitlist to our PE group in this study, what we found was that a significant time by condition interaction. So not surprisingly, our trauma-focused treatment group got better in terms of suicidal ideation reduction over time. Our waitlist group did not, and there was a significant interaction over time, such that the PE group got better faster, essentially, than our waitlist group. However, when we compare PE to our supportive counseling intervention, what we found was evidence that both treatments were effective in reducing suicidal ideation over time, which was not what I would have expected, and it raises some questions about what mechanisms of action might be happening in these treatments in terms of their impact on suicide risk. What was also really interesting, though, is when we look in the follow-up window. So after treatment's over, we had the opportunity to measure people up to 6 months later. And what we found was that in both active treatment conditions, there was a significant increase in suicidal ideation, an increase that we did not see in terms of PTSD severity. Individuals were not returning to their baseline level of suicidal ideation, but essentially they were not maintaining the gains that they had earned throughout therapy. So this, to me, suggests the possibility that trauma-focused treatments are safe for people with some level of suicidal ideation, but they might not be sufficient for reducing suicide risk when presented alone to patients with suicide risk. I followed this with an exploration of trying to understand mediators of change in suicidal ideation over time in this same active duty sample. So to do this, I used a model that's called a parallel mediation model. And the basic idea here is you can, of course, map over time the change in suicidal ideation, but then you can add to that model a series of different mediators. So for this particular analysis, I was interested in 3 mediators. I was interested in depression, for reasons I've already mentioned, as well as PTSD, and social support, because of the conceptual models that I presented to you earlier, suggesting that social support and social connection is really important for understanding suicide risk. When we ran these models, what we found was that, consistent with what I've already described, there was a significant reduction in suicidal ideation over time. There were also significant reductions in depression and PTSD over time, but non-significant change in social support. That's really interesting from the perspective of trying to intervene to reduce suicide risk for patients with PTSD, and we'll return to that point later because I think it's really important. When each of these 3 mediators were in the model, there was evidence for full mediation, but this effect was driven by changes in depression severity and not PTSD. When we included treatment condition into this model to explore evidence for what we call moderated mediation, we basically found that this effect held whether the person was in PE or supportive counseling. But then I took a step back and I thought about some of the data that I presented to you earlier, where I explored evidence for bidirectional change between PTSD and depression in those other data sets. And as a result of that research, I decided to explore what's called sequential mediation. The idea here is you can run a series of models where you look at how, for instance, depression change might lead to changes in PTSD severity, which then might lead to changes in suicidal ideation, or the opposite, a model where those effects are reversed. When we ran a series of these models, what we found was evidence for this one. Essentially, in this data set, there was evidence from multiple different tests and comparisons that it seems that PTSD symptoms are changing first, which then lead to subsequent changes in depression that ultimately drive changes in suicidal ideation over time. So to me, these findings are important, again, for thinking about mechanisms of where might we need to intervene for patients with PTSD and suicidal ideation. Importantly, we've replicated these findings in a variety of other samples. So we've replicated these findings in a paper looking at civilian adults with a variety of anxiety disorders, including PTSD. We've also replicated these findings in a sample of adolescents who'd been exposed to sexual trauma and who received trauma-focused treatment. But what's notably missing from all these studies is evidence that these treatments are safe in really high-risk samples. And the reason why this evidence, by and large, is missing is that most PTSD trials exclude patients that are at high risk for suicide. So a lot of PTSD researchers are terrified of patients that are at high risk for suicide, and they're worried that perhaps the treatment is going to make the patient worse or destabilize them. And for that reason, these patients often aren't included in these trials. In light of this, I'm running an open trial right now to try and explore strategies for addressing suicide risk in these higher risk samples. To do that, I'm collaborating with a variety of community mental health centers throughout the city of Philadelphia to train them in a model that I developed by integrating PE with a suicide prevention strategy. The suicide prevention strategy here is called CLASP, which stands for the Coping Long-Term with Active Suicide Program. Now, this is a brief therapeutic program that was originally developed for patients at very high risk for suicide on the inpatient unit, the psychiatric inpatient unit, to help them discharge from the hospital. And the reason why I selected this intervention was that the intervention includes a focus on improving social support. Now, you'll remember when I was looking at some of the mediator findings earlier, social support was not significantly changing in the PTSD treatments as they stood. And given that social support is so important for suicide risk in just about every theory of suicide risk, we wanted to have a treatment that intends to target social support. CLASP is also intended to facilitate problem solving. So the idea is helping patients think about new opportunities for thinking through options when they're in a suicidal crisis. It's also intended to help with treatment adherence. So part of the strategy is helping patients to do their homework through PE. And it's intended to target hopelessness. There's a component of the treatment that focuses on improving values, improving connection to making a life worth living. And we received some funding from an internal foundation grant to support this open trial research. So far, I've trained 17 different therapists to do this project. We've received universally positive feedback about this integrated protocol. But we've had a hard time recruiting patients into the study, in part because of the high turnover in our local community mental health centers. I don't know if that's the case here, but of the 17 or so therapists that we've trained, about 10 of them are no longer working in that facility, which makes it really hard to see how their patients are going to respond to this treatment. So we're putting in applications all the time to try and get funding to do this in a variety of different ways, and we're hopeful that we'll be able to do that in the future. So if we know that trauma-focused treatments are associated with reductions in suicidal ideation, we're still left with this big question that clinicians always ask us, which is, well, how do I know which of my patients are at the highest risk? And how do I know when a patient is going to transition from looking lower risk to suddenly looking at much higher risk? And so this takes me to the second area of research that I'll present to you today, which is about this digital phenotyping research. And the key questions here are which PTSD symptoms can influence mood and suicide over time? And importantly, can we catch this in real time? The long-term goal for this area of research, of course, is to intervene on what we discover from these digital phenotyping strategies to try and reduce suicide risk in real time. But to do that, we have to collect a lot of data about how suicide risk changes. First, we needed to decide what we should be measuring over time, because with digital phenotyping, you can measure a lot of different things, and we wanted to make sure we were targeting the right kinds of areas. So to do that, I first wanted to explore which symptoms of PTSD are most strongly associated with suicide risk. So I published a paper where we looked at 2 different samples of individuals who'd been exposed to trauma. So the first was a sample of individuals, community members, essentially, who had some trauma exposure. And we explored the correlation between their PTSD symptom clusters and suicidal ideation. What we found was that each of the PTSD symptom clusters were significantly associated with suicidal ideation, but it was primarily arousal, so here think sleep problems, and negative alterations in mood and cognitions, again here think social connection and interpretations about social connection, that were more strongly associated with suicidal ideation than the other symptom clusters. And we replicated that effect in a sample of trauma-exposed psychiatric outpatients, and we now have a paper under revise and resubmit showing the exact same thing in a sample of veterans. So we think that this is holding out to be true across the board, that it's these 2 symptom clusters that seem to really matter. So in light of that, I put together funding for an internal grant at Penn to try and do digital phenotyping to track these symptoms over time. And the strategy that I'm using here is a combination of approaches. The first is using a Fitbit device. So we give individuals a Fitbit device to wear continuously throughout their participation. And then we also use ecological momentary assessment, which is a strategy for sending active text messages, essentially, to participants to ask them about a number of different kinds of things. The first pilot study that I'll present to you was a sample of 40 participants that I recruited from my center at Penn. These are patients with a principal anxiety diagnosis who were receiving cognitive behavioral therapy for that anxiety diagnosis. And they had a variety of different kinds of principal diagnoses. Participants here were around 30, primarily female and primarily white. They were also primarily single with some college education by and large. We asked them about a number of things in this study, but I'm just going to present to you a few that were of interest. So we, of course, did some self-report measures for principal diagnosis. We also administered the Beck Depression Inventory, which is a measure of depression severity that has an item about suicidal ideation. And then we used a couple of different items from the PROMIS scale. Can you raise your hand if you're familiar with the PROMIS scale? Have you heard of that? So just about everybody. For those of you who don't know, these are freely available measures that you can use in your research if you're interested. And we set this up such that participants got compensated more the more questions that they answered, which was a strategy to try and get them to respond to us. And that was important because in this study, we assessed participants for up to 20 weeks. It's a long time to be answering questions. We only sent them a few questions each day, but we measured them for a really long time. We narrowed in on this Fitbit device so that we could measure, of course, physical activity and heart rate, but importantly, I was mostly interested in the measure of sleep, or what we think about as nocturnal wakefulness, the extent to which a person is awake in the middle of the night when they really should not be. That's a variable that seems to be important for suicide risk. We have over 4,600 observations on this relatively small sample, so I'm swimming in data at this point, and we're still trying to figure out all of the interesting things we can do with this data, and I'll present to you just one particular area today. Oh, and I'll mention we used a commercial product, the Fitbit here, instead of a scientific grade monitor. So does anyone here do research on actigraphy? Could you raise your hand, or wearable devices? Okay, so there are scientific grade devices that can be used for measuring things like sleep. The problem with them is that they're really ugly, so people won't wear them. They're really expensive, so they're like $1,000, and they have to be charged very often. The Fitbit device, in contrast, is pretty affordable. It's about $100. It's not ugly. Well, it's not. I don't think it's very ugly. Most of our participants actually like wearing it. And it can charge, a charge lasts about 5 to 7 days for the Fitbit device we used in this study. But most importantly, we wanted to make sure that if we get a signal here that matters, that we can eventually scale up the findings, which we'll never be able to do with a $1,000 actigraphy device. So what we're losing in precision, I think we're gaining in terms of the potential implementation benefits of this down the road. Also, I'm comfortable with there being some amount of noise in the data that we collect with the Fitbit, provided that the noise is meaningful. Meaning, if we know that the device is reliably unreliable, can we still make meaning of that data for understanding, for instance, how sleep might lead to problems with mood or anxiety? So the first series of data that I'll present to you are about this effect of nocturnal wakefulness on next day depression. So the idea here is, to what extent does being awake on a given night correlate with how people are doing in terms of their depression ratings the next day? And you probably won't be surprised to learn that there was a correlation here, so that the more someone was awake when they, in theory, should be sleeping, the worse their next day reports of depression were. And to demonstrate this to you, I'm going to present a case study showing this effect over time. So essentially, the blue here documents minutes awake. So this is how many minutes awake a person had on a given night using the Fitbit data, mapped against next day ratings of depression. And what we see here, this is certainly not a perfect correlation. For this particular person, the correlation was a moderate one of 0.49, but there appears to be a clear signal here. And just to make sure we weren't losing our minds, we did this with another person for a sanity check. And what we found was a similar sort of effect. Again, it's not a perfect correlation, but there appears to be a signal here for some individuals. But what I was noticing in just sort of visually inspecting this correlation for all of our 40 participants was that there was a lot of variability in this correlation. So it seemed really strong for some participants, but not for others. Because my research is on suicide, that was a variable that I decided to explore as a potential moderator of this effect. So the idea here was I then added into our model a variable that included whether someone had suicidal ideation at baseline or depression at baseline or neither. And when we added that into the model, we found a significant interaction. And to demonstrate to you what this looks like, essentially, for most individuals, this is just a random snapshot of 6 of them, for most individuals, there was a significant correlation between nocturnal wakefulness and next day depression if they had a baseline report of suicidal ideation. If they had depression but not suicidal ideation, that effect tended to still be there, but it tended to not be as strong. But the effect essentially reversed altogether for individuals who had neither depression nor baseline suicidal ideation. And the reason why this matters is I think it speaks to the importance of using a precision medicine approach, that it's not likely the case that sleep is a risk factor for everybody. In fact, there's a lot of evidence that it's not. But for some people, particularly for those people that are at risk for suicide, maybe sleep is a marker that we need to be paying a lot of attention to for patients with anxiety disorders. In terms of next steps for data collection for this research, I'm exploring this research in samples of people that are living with HIV. The reason for that is individuals with HIV are much more likely to be exposed to trauma. They're much more likely to meet criteria for PTSD if they have been exposed to trauma, and they're much more likely to die by suicide compared to people that are not HIV positive. We also have a grant with the Department of Defense to do this digital phenotyping research with Marines, recruited from Camp Lejeune in North Carolina. We're waiting on regulatory approval to get started with recruitment for this, but we're hopeful that any day we'll get permission to be able to do that. And then I'm also collaborating with some colleagues who do research on polysonography data to try and catch people in the sleep laboratory to figure out what sleep signals might be important for predicting suicide risk over time. I'll present to you, we have some preliminary data from our HIV sample that I'll present to you because I think it's really fun and exciting and a good way to wrap up this overall area of research. So I recruited 10 individuals who were living with HIV who had had past month thoughts about suicide, all of whom had been exposed to a trauma, some of whom met criteria for PTSD, some of whom did not. And I measured their daily changes in suicide urges over time. And so this is one individual mapping out their suicide urges on a 0 to 100 scale using a visual analog scale that's actually highly predictive of future suicidal behavior. And what you can see in this one individual is that there's substantial variability over time. This, I think, is the one important take-home message that I've been learning throughout this body of research is that there are not high-risk people and low-risk people. There's tremendous changes in risk status from hour to hour and from day to day. And I think this person's changes in suicide urges that we captured really reflects that well. But we also collected data about the timing of when suicide urges were at the highest. And so for this particular person, it tended to be mostly at nighttime or in the early morning hours that they were saying their suicide urges tended to be the highest. And so based on that, I wanted to map out the overall frequency distribution of when suicide urges were the highest across all of our 10 participants. And what I found was a really interesting effect. So we found that 3 o'clock in the morning was reliably showing up, and this is raw data. So this is not taking into account the likelihood that someone would be awake at 3 in the morning. This is just pure count data of the timing when suicide urges were the highest per the individual's report. 3 a.m. was standing out as a time of high risk. Now that's really interesting because when you look at mortality data sets, so the timing of death for people that die by suicide, does anyone want to guess what time do you think would be the most likely that people would die by suicide? What would you guess? So maybe 3 a.m., it's 2 to 4 a.m. And so that's interesting because these mortality data sets, we have no ability to understand what's happening between 2 and 4 a.m. We just know that that's when they happened to die. We don't know whether these are people who woke up in the middle of the night and were distressed and unable to fall back asleep, or people who were not sleeping at all. Maybe they're on shift work, for instance. And so I think this is a really exciting area of research to get into to try and track the change over time in suicide risk. And there's a lot more that we're planning to do with these analyses. So to summarize, so we know that PTSD is associated with elevated risk for suicide. We know that trauma-focused treatments can reduce suicide risk, but perhaps not sufficiently, and likely not sufficiently for those patients that are at really high risk. We think that depression and PTSD symptoms might be critical mechanisms of change in suicidal ideation over time. And we also think that depression, that sleep is intimately linked with depression and other markers of health over time, including social support, and that if we can measure changes in sleep, we might get a better sense of changes in depression and suicide risk over time. So in the future, I plan to continue on with randomized controlled trial research to explore the effect of these integrated treatments and to continue exploring these digital phenotyping strategies. So as I mentioned, I'm planning to continue to build this program of research using this integrated treatment of class PE, looking at strategies in the laboratory to enhance inhibitory learning for patients that are at risk for suicide, and to understand psychological and biological mechanisms of these effects. I hope to explore this research in more diverse comorbidities and to explore real-time intervention design, like I mentioned before. But once we have an intervention that we think works in real time, we then need to explore how to optimally deliver that intervention to make sure that people are actually using it when they're at high risk. And I see these two areas of research as very mutually influential and informing one another. So I'll just take a moment to thank all of my many collaborators who've been so helpful for me with this research, including Edna Foa and Anu Asnani, as well as my grad advisor, Michelle Krask, and many, many other people, too many to be named. And I'll pause here, and thank you very much for your time. So I'm happy to take questions, and we've got about 12 minutes for some questions.
Thanks for the talk. So what do you imagine interventions looking like? Maybe some clinicians would be happy to get a phone call at 3 in the morning, but that's maybe not what the intervention would look like. So what would it be?
Yeah, I think it's not sustainable that the intervention is going to be a person. I think we are exploring in our clinic, we have a grant under review right now to use a telehealth strategy to deliver suicide prevention, not based on the fact that you're at risk right now, but just because you're at risk in general. I foresee that these interventions are going to be more technology-based interventions. So for instance, we know a ton about strategies for improving sleep, using things like sleep restriction therapy. And these are very basic principles that have already been translated into digital apps to try and improve sleep that are widely distributed in the VA, for instance. But trying to map the delivery of those evidence-based principles to, hey, it looks like you're having a hard time or a hard week right now, have you considered doing this? I think in reality how it will appear will be a menu of options of things to try. So for instance, distress tolerance skills, strategies for improving communication, strategies for reaching out for support, strategies for managing sleep, perhaps even strategies for managing substance use. I think it's every person who's at risk for suicide looks slightly different than the next. And so I think our strategies are going to need to be multifold, and they're going to need to focus on things that also aren't just mental health and that are more about global connection and building a sense of community and building a life worth living. Things like focus on what your values are and what you want to be working on in your life. That's what I envision down the road.
Excellent, for a great talk. I'm a primary care physician, and so I'm sort of, thinking about this not so much from the downstream treatment that mental health professionals would deliver, but what can primary care practitioners do to help identify people at risk and then get them into the best available treatments. I have a couple-part question. One is, if you were to create a Venn diagram of PTSD, depression, and suicide attempt, what would that look like in terms of the overlap among those three factors?
Yeah, it's two really interesting and different questions. So let's start with the second one first. I heard a talk from Craig Bryan, who's one of my collaborators, and he's our associate professor at the University of Utah. And he shared with me this finding that has been pretty well replicated, that when you look at meta-analyses to try and understand the differences between thinking about suicide versus engaging in suicidal behavior, what you tend to find is that for thinking about suicide, predictors are things like depression, PTSD, anxiety, substance use, like the full gamut of all the things you think would be bad. That tends to predict thinking about suicide. But when you tend to look at predicting suicidal behavior, PTSD tends to stand out as a predictor much more strongly than depression. And so I think that it's clear that there's overlap here. The vast majority of people who have PTSD either have symptoms of depression. Many people meet criteria for depression. So these are important and they're related, but I think that they're also distinct. And I think that some of the things that make them very distinct are along the hyperarousal symptoms, which are not present in the context of depression, and also some of the avoidance symptoms too, which are also sometimes present in depression, but they look quite different. It's not that I'm avoiding things because I'm afraid of them, it's that I'm avoiding things because I just don't feel like it. And so perhaps that will lead to some interesting insights over time. On the primary care side, I think that's also a really important area. Many of you may be familiar with the attempt to roll out universal suicide screenings in primary care and in clinics sort of across the medical spectrum. And I'm doing some research right now using the EHR to understand a lot of things about how those assessments are going. One of the things that we're finding is that there is enormous variability in how these universal suicide screenings are happening. So ranging from they're not to we're asking about depression, and if you don't have depression, we don't even ask you about suicide risk, which is really common in some clinics, to doing it all and doing really intensive suicide risk assessments. And so I think the number one thing that I think primary care providers can do is to ask about suicide, because not everybody who's reporting thoughts about suicide is going to report that they're feeling depressed. These are different. I can both feel like I want to die, but not feel like my mood is lower. There might be moments when my mood is low, but for the past 2 weeks, my mood has been fine, but I know that when I get to the anniversary of my husband's death, I'm going to kill myself. That's different. And so I think the best thing primary care doctors and physicians across the medical spectrum can do is to ask about suicide risk. Then it's on mental health providers like myself to do a better job of helping you triage what to do next, because I think there are very brief strategies for reducing suicide risk. Some of you may have heard about safety planning, which was developed by Greg Brown and Barbara Stanley. There's also crisis response planning. These are both meant to be typically one-time interventions to reduce suicide risk. They're pretty easy to learn, and there's evidence that they can be implemented across the medical spectrum. But for very busy clinics, I think it's not realistic that the clinicians themselves are going to be doing it. So I think it's on mental health professionals to help partner with physicians to do more to once we know that a patient is at risk, to help them with a warm handoff to make sure that they get the services that they need.
Hi, so our program actually provides CBT for suicide prevention, and so I'm curious about when you were talking earlier about treatment of PTSD, and then sometimes finding that suicidal ideation might go back up after treatment has been completed, and I'm wondering if you have any thoughts about the implication for thinking about patients who need maybe a lot of different kinds of treatment, and maybe if they should have PTSD treatment first before going into a suicide-specific treatment, or I'm curious about your thoughts on that.
Yeah, it's a great question, and the reality is, clinically what tends to happen, as you likely already know, but for those of you who don't, we tend to hear a lot. This patient has PTSD, but they're also having thoughts about suicide. We should really wait to make sure that they're stabilized until they get their PTSD treatment, meaning that their suicide risk has resolved. The problem is, as you might guess, based on this talk and probably other things you've read, I'm skeptical that suicide risk is going to resolve for that kind of person if it's their trauma-related distress that's driving their suicide risk. So in clinical practice, by and large, what's often happening is this attempt at a sequential approach where we might refer someone for a suicide prevention service and then maybe eventually refer them for PTSD treatment. And I think, again, that reduces access to the treatment that's likely to actually reduce suicide risk for that person. Because we're so in the early stages of this area of research, there's not enough evidence to guide what kind of sequential approach might be most appropriate. I think that the thing you have to think about when you're working with patients that are at risk for suicide is that you have to capitalize on the time that you have with them. So this is especially true the higher in severity that you get, so when you're working with inpatients. It's totally possible that you might get a patient while they're on the inpatient unit, introduce a treatment, get to work with them twice, and then they leave the inpatient unit and they never come back to their follow-up appointments with you. So I think you're absolutely right. We need to be thinking about targeting lots of different kinds of areas of focus. I think the best thing we can do is start with the basics, which include really good assessment, safety planning or crisis response planning, and then provided that the person comes back, building on these other areas slowly and over time. I think it's hard to get people to stick with the treatment often, and so those quick approaches I think are good, at least for doing something. It's probably not sufficient on their own, but at least it gets the ball rolling. Okay, great. Well, thank you all so much for your time. I really appreciate it.